This concludes our discussion of Chapter 8 on joints or articulations from our Human Anatomy and Physiology text. This part, we're going to talk about the elbow joint, the hip joint, the temporomandibular joint, and some injuries and diseases of joints. So the elbow joint is a hinge joint, as we saw. It's a uniaxial joint between the humerus and the ulna. Those are the two bones that make up the hinge joint. You can see a bursa right in here. You can see a tendon, a synovial membrane, a joint capsule, synovial membrane on the inside of that, piece in the fluid, articular cartilage, all the familiar parts of a synovial joint. You can see how nicely wrapped up the joint cavity is, of course, with the joint capsule, and some of the ligaments that are unique in the elbow. The radius is not really part of the hinge joint in the elbow, but it does ride along on one part of the condyle, on a particular condyle of the humerus called the capitulum. So the radius head just rolls along the capitulum during flexing and extending of the elbow, but the radius can also rotate. A pivot joint exists here, and this little annular ligament wraps right around the head, starting from here on the lateral surface of the ulna, right around, or the medial surface of the ulna, right around to the outside. Actually, it's hard to say what we're looking at here. It looks like they have the radius drawn above. Anyway, we'll take another look at this joint, probably a little more anatomically correct look at it in a second. There's a dissection showing some of the ligaments that are found in the elbow joint. Okay, so this is probably a little easier to see. Hopefully, we're looking at the ulna, the medial bone of the two forearm bones, forming the hinge joint with the humerus. And now we can see the radius is distinctly lateral to the ulna, which it should be. And you can see the annular ligament now wrapping around from the lateral surface of the ulna, which I was starting to say last time, and it wraps around the radius back to the ulna. And looks like it's very hard to draw this in any kind of accurate perspective. Some other ligaments that are present in the elbow are here that would be familiar to someone who treats a lot of sports injuries and so forth. The hip joint is a ball and socket joint, a multi-axial joint much like the shoulder joint, except that the acetabulum, the socket of this ball and socket joint, is much, much deeper. Look how deeply the head of the femur invests itself into the acetabulum and into the pelvic bones. So that's a pretty amazing thing. It's a very, very stable joint, relatively speaking, and yet it has quite a bit of range of movement, not like the shoulder by any means. Again, I can see the joint capsule and a couple of ligaments. There's actually a ligament within the joint, analogous to the fact that there's ligaments in the knee joint, to hold this, to keep the head of the humerus securely in the acetabulum. And there's a beautiful dissection of a cadaver showing the hyaline cartilage, the articular cartilage of the head of the femur, and you can see some of the joint cartilage here in the acetabulum, the pelvis. You can see here some of the ligaments that additionally add stability, holding the head of the humerus into the acetabulum, yet allowing the flexion, extension, abduction, and adduction of the femur within the relative to the thigh. You can see a bursa peeking out there. The femur, this is a posterior view here, and the ischial tuberosity is right here. So this is the ischium bone, the posterior bone of the lower pelvis. And here we can see the greater trochanter and lesser trochanter of the femur, two huge processes that allow the attachment of tendons to very strong muscles that allow us to move the leg with the body weight upon it, as well as any weight that may be carried in the pectoral girdle and the arms. Another look at some of the ligaments that knit this joint together. They get a very, very tough joint, rarely dislocates. Shoulder quite often, and relatively speaking, I should say, not often, but in sports injuries, but not the hip so much, although I have encountered a number of students who play soccer and other sports who have had to have surgeries because of injury to the labrum of the hip joint, as you'll see in a second. Yes, we don't have a beautiful picture, cartoon of the hip joint dissected, so we can see the labrum is analogous to the labrum we saw in the shoulder joint. It sort of surrounds the joint structure. So the labrum is here. We should have made note of that while we were here, thinking there would be a cartoon. So there's the labrum of the hip joint. It may be torn. The cartilage may be torn here as well in the hip joint. The hip joint may be replaced. We'll leave that discussion for a bit later. Then we come to the temporomandibular joint. We saw that the mandible articulates with the temporal bone in the temporal fossa, forming the temporomandibular joint. And it turns out that the temporomandibular joint is a source of some difficulty. It actually is unique in a sense because it has an extra joint cavity and synovial fluid chamber. In a sense, there's one joint cavity here filled with synovial fluid and surrounded by a synovial membrane, but then there's a so-called articular disc, and then another separate sort of synovial chamber or synovial cavity there with synovial fluid in there. And the upshot is that there's a lot of freedom of movement in this temporomandibular joint that otherwise probably wouldn't be present in a typical synovial joint. So what they're trying to show in this picture is that we can elevate, depress, protract, and retract the mandible, but there's also quite a bit of lateral excursion, they're calling it. So this joint can really do a lot of moving. The temporal bone can move significantly relative to in every direction relative to the temporal bone, density of the mandible relative to the temporal bone, except it can't sort of dissociate itself from the mandibular fossa. But a lot of movement because of that unique characteristic of the joint construction. Temporomandibular joint can also be the source of some very painful syndrome. Grinding of the teeth is thought to contribute. It's not been established absolutely, but people who grind their teeth a lot, especially in the sleep, tend to have a higher incidence of severe temporomandibular joint pain. People that have arthritis may well have arthritis, inflammation in this joint, which can be very, very painful. Injury to the mandible can result in temporomandibular joint syndrome, which is a pain syndrome. So we have irritation, inflammation, and degeneration of the joint, and debilitating pain. So that's a problem. People may be required to wear a brace to reposition the temporal or the mandible and the temporal bone correctly, so that and maybe even move the teeth so that possibly misalignment of the teeth in the mandible and the maxilla can result in then misalignment of this joint during chewing and cause some of that irritation and inflammation. Okay, so that thus ends our discussion of the individual joints of the body. Hope you've enjoyed that very interesting look at this very sort of almost surprising structure of the ligaments and so forth of all these joints. All right, arthritis. What is arthritis? Arthritis just means inflammation of the joints or a joint. But when we say arthritis, we typically refer to three different processes that lead to inflammation of the joints. One is called osteoarthritis. It's age-related and sometimes called wear and tear arthritis, but I don't think that's a great description of it. From a cell and molecular biology standpoint, it's thought to be the result of chondrocytes with aging changing the way they operate. Like osteocytes, chondrocytes are always replacing cartilage and repairing cartilage, and with age, it's thought that the degradation phase of repair, right, if you're going to replace something, you need to take out the old and put in the new. And the degradation phase of that repair job, that replacement job, continues unabated, while the replacement part, the synthesis phase of the replacement, slows down. The chondrocytes just can't keep up, and so there's loss over time of the articular cartilage. And eventually, the cartilage starts getting rough, and we begin to hear a sound in there as the joint moves. If the articular cartilage is completely gone, and we may hear bone rubbing on bone, or an especially painful and noisy process called crepitus. Crepitus again can refer to cartilage sounds, but any unusual sound, abnormal sound in the joint. Osteoarthritis tends to arise in particular joints early on in the disease, and more commonly than other joints in most people. So in the lumbar vertebra, the lower back, a lot of trouble people have with the back. Fingers, the thumbs particularly, that's usually the saddle joint in the base of the thumb is often the very first place where arthritis begins to attack. Knuckles and knees and hips. So some difficulty in the future if you have a predisposition to osteoarthritis. The biggest thing you can do to prevent osteoarthritis is exercise. Exercise will promote healthy joint cartilage maintenance and reduce inflammation in joints. So those are two very concrete and specific and well-established findings. A very good idea to get in the habit of exercising now. Rheumatoid arthritis is altogether different. Rheumatoid arthritis is an autoimmune disease. It's an autoimmune disease in which inflammation is the hallmark. And so once the immune system begins to attack substrates within the joint, we have degradation of the joint and inflammation. And so we're going to have a lot of excess synovial fluid that may appear in the joint for a period of time. The synovial membrane may begin to thicken, forming what's called a pannus, which begins to interfere with the range of motion of the joint. And the cartilage, the articular cartilage, will eventually completely degrade, and then it'll start to degrade the bone that used to underlie that cartilage. Once the cartilage is destroyed and the bones are in contact with each other, the pain may be so great that using the joint becomes essentially impossible, and inactivity eventually gives rise to ankylosis, the fusion of the bones right together, so there isn't even any longer a joint there. And here's a picture of a hand whose knuckles, whose joints of the digits and the metacarpals have been destroyed by arthritis. There's an X-ray of such a case. You can see that the hyaline cartilage is gone, and the bones have been rubbing together and actually grinding away the bones where they used to form the joint surfaces completely destroyed. So rheumatoid arthritis had been a completely debilitating disease that would render someone an invalid for the rest of their life for the most part. But with modern chemotherapies, drugs that can fight inflammation, really we've rounded the corner in which it's just a chronic disease that can be well managed, and people can have a relatively normal life and have lots of activities that they enjoy doing, even though with this disease. So what are some of the drugs? Non-steroidal anti-inflammatory drugs, NSAIDs. If you're lucky, you can get by for a time on those kinds of drugs. Steroidal anti-inflammatory drugs are much more powerful, but have side effects. So it's not the kind of thing where you want to just get on steroids and stay on there for a long time, even though they're very, very powerful. It talks about some of the side effects when we talk about the endocrine system. So there are also disease-modifying anti-rheumatic drugs, such as methotrexate. There's actually a whole lot of this, but I didn't think I thought you'd become overwhelmed with anxiety if I posted like a long list of drugs and you think, this is overwhelming, I can't learn all these drugs. I didn't really want you to learn all the drugs, but I just want you to know that there are. I thought you might even recognize the names of some of the drugs from other things that you've learned about in science and in family and in your work maybe. So some of these are fairly toxic, also have some bad side effects. So methotrexate is a fairly nasty drug. It's really a drug that blocks cell division. So in a place where you have a lot of lymphocytes or immune cells multiplying and therefore becoming inflamed and forming this army of inflamed cells in the joint, methotrexate would stop that process, but it also stops a lot of other cells from dividing. It's kind of nasty stuff, plus liver damage and so forth. The new discoveries that the real turning the corner on many autoimmune diseases and inflammatory diseases is biologic agents, which are oftentimes humanized synthetic antibodies. And antibodies are defensive proteins designed to bind to a foreign protein or chemical that comes in the body and antibodies have been designed in such a way that they bind to chemicals that are the signals for inflammation in the body, or for the receptors of chemicals that are signals for inflammation, and anything that can block the inflammatory cascade of events so that the inflammation subsides. That's the kind of thing. I just put 3 that I thought were the most familiar sounding to me from television ads and from various people I've known that are that have either Crohn's disease or arthritis. And these are a couple. There are probably about 6 or 7 more that are very, very commonly prescribed, very powerful and very expensive but very effective drugs. Okay, and finally, a third kind of arthritis, gouty arthritis. Gout is a condition in which if uric acid, a normal metabolite of nucleic acid base metabolism, accumulates in the blood, if the levels of uric acid rise, then they accumulate also in the body fluids and in any fluids derived from the blood, such as synovial fluid. And so if there's a high enough concentration of synovial fluid in the synovial, or of uric acid in the synovial fluid, it can precipitate. When something precipitates, it means it forms a solid. And in this case, it forms crystals that are razor sharp. And so usually starting in the great toe, gout causes a severe pain and inflammation in that joint of the metatarsal phalangeal joint of the big toe, the hallux. So very painful and damaging. Most common cause is probably alcohol abuse. Alcohol consumption tends to promote higher uric acid concentrations. Some people, though, just have a genetic predisposition. They have high uric acid concentrations in their blood and are prone to have this kind of problem. There are drugs that are used to treat that kind of situation, to bring down the uric acid concentrations. Men tend to have higher uric acid concentration because estrogen promotes excretion of excess uric acid. Other types of injuries, I just want to mention sprains, because so many people get sprains, and I thought you should know what they are. You'll encounter them if you work in any area of healthcare. Sprains are injuries to ligaments in which the ability of a ligament to resist stretch has been overcome, and it has forced that ligament to stretch beyond its normal length. So a sprain can occur in the most limited sense when we simply stretch a ligament. It will never recoil. Now it's longer, and there's going to be a loss of joint stability. Right? If the ligaments are longer, then the joint can flop around more. That's a problem. A more severe injury is one in which there's tearing. If the ligament tears as well as stretches, then it'll take a bit more healing and a bit more care and attention to get things back to normal. But there will surely be a loss of joint stability, which we're going to have to compensate for. If there's a complete separation of the ends of a torn ligament, then usually surgery would be required, but not always, to reconnect those ligaments. And the nice thing about that is we can reconnect them at a little shorter length than they would have healed up naturally, and restore some of that lost stability. So anyway, when the stability of a joint is lost due to a sprain or a healing from a sprain, it's important to compensate. We've already said that the greatest contribution to joint stability is muscle tone and muscle strength. So the thing that's going to happen is an extra diligent approach to exercising the muscles that of a particular joint where a sprain has happened, in order to compensate for the loss of stability. Lyme disease is a bacterial disease caused by Borrelia burgdorferi, a spirochete bacteria that's carried and transmitted by ticks from deer and mice. So the black-legged tick is the vector or transfer of this disease to humans, and a bacterial infection of Borrelia will cause a bullseye rash on the body sometimes. It's very characteristic looking, and it can't be mistaken for anything else, but the problem is it doesn't always occur, or it may not be noticed if it's in a place on the body where it's not easily discovered, and it's only short-lived. Flu-like symptoms, fever, headache, and fatigue. We often seasonally experience these kind of symptoms, and we shrug it off, and we just grin and bear it and go on with our lives. So people that get Lyme disease may very well not know that they have the disease. It will go undiagnosed. The problem is that the longer this bacteria is allowed to run rampant in your body, the more damage it will cause. It can damage organs and so forth. It can colonize and damage organs, and certainly the joints. that causes arthritis in the joints, which may be permanent, is treatable with antibiotics, but not until you discover it. So an effort is kind of being made to keep clinical staff aware of and in mind of the possibility of Lyme disease, especially in certain parts of the country, the Northeast and along the California coast. Carpal tunnel syndrome. In the lab, when we looked at the bones, we saw that two of the carpal bones have a process extending anteriorly that once the transverse carpal ligament is wrapped across the top of them, it forms a tunnel through which all the tendons must pass that allow flexion or cause flexion of the digits. So when you want to close your fist, you're going to operate these tendons. And if there's a occupational exposure to a high frequency of repetitive movement of the digits, it can lead to inflammation in here and swelling and entrapment of these tendons and their tendon sheaths within this limited space in the carpal tunnel. But it also will impinge upon the median nerve and cause pain, severe pain potentially, in the hand and wrist. So it's a very tough thing when you get carpal tunnel syndrome to live with, until finally a surgery can be enacted to just cut and open up that transverse carpal ligament and allow all the swelling to kind of rise to whatever natural level it will, release the tension on that median nerve and let things heal up and resolve that problem. When osteoarthritis becomes bad enough, and some people have very bad osteoarthritis in their knees to the point where it becomes difficult to get around at all. If it's late enough in life, the surgeons will often schedule a knee replacement. The knee replacement means a bunch of carpenters coming in with their toolkits, heavy-duty toolkits, and sawing and drilling and putting in some synthetic machinery that will replace the actual knee joint in both the femur and the tibia, and allow people to have a pain-free movement of their joint in the future. And it's quite a miraculous thing, and the technology keeps improving. The materials that are used in the geometry of them so forth, and the way they anchor themselves into the bones. So it's just a constant improving scenario, and it's becoming quite a routine thing to have knee replacement if you do have any kind of difficulty with pain and locomotion with the knees. It's a non-trivial problem to deal with the pain during physical therapy and the rehabilitation after the surgery, though, and so that's something to be considered. But it is well worth it for people that have a lot of knee pain. A partial knee replacement, perhaps there's a perfectly good condyle on the femur and tibia, and yet there's also one that's very, very degraded. Then it might be worth just replacing the joint surfaces on one of the condyles. So hip replacement is quite common also nowadays. So if you have arthritis in the hip or a bad fall that has left irreparable damage to the hip joint, a hip replacement, if there's enough, if this body is strong enough to accept it, might be the solution. And the list keeps growing as the technology improves. So soon we'll have bionic people running around and doing miraculous things. Here's an older, probably a pretty old picture now that I put in here. You can see quite a while back when this was inserted in here, possibly, maybe not even that date. But anyway, you get the idea of the part of the joint hardware that goes into the acetabulum, and a long trochanter jams down into the femur after cutting off the femur at the neck, and have a fine replacement for that structure. Here's a picture of an X-ray of a post-operative knee replacement. So the rest of these tables are just showing you the naming of the synovial joints of the body. Many of the synovial joints are just named for the two bones that come together to form the joint. So I wouldn't expect you to spend a lot of time worrying about that. It's just a good rule of thumb to be aware of, so that you can make intelligent reference to joints if you're having a conversation with somebody who's knowledgeable about anatomy and physiology. And thus concludes our discussion of Chapter 8. So join me next time as we begin to discuss muscles, the miraculous subject of of muscles and muscle cells and all their cytoskeletal components and everything else that allows them to do the magic of converting chemical energy into mechanical energy.